Welcome to our Unclenched podcast.
Yay!
We're here together. This happens only once a year at the ICCMO Conference. And I'm so glad to see you, Priya.
Yeah, it's so good to see you. I was missing you, and we need to get together more than once a year.
I know.
I'm glad that you guys were able to find this great studio that we can record in. This feels so just lovely.
Yes.
Why don't we start by telling our viewers what ICCMO is?
Okay.
And then we can kind of delve into what this podcast is about. What do you think?
Okay. Yeah. So ICCMO is the International College of Craniomandibular Orthopedics. And I've been involved with ICCMO. I was trying to think, it's probably been maybe 12 years or so now. And I've been on the Board of Regents, and we bring speakers in to try to put together the body with the TMJ. It's going to be a great... Did you look at the schedule?
Finally. Yesterday.
Yeah. So did you... I mean, there's a lot of great stuff. Yeah.
Your team is presenting.
My team.
Yeah.
I'm very proud of my team.
I'm so
They're my
proud
girls.
of them.
They're presenting.
Yeah.
And they're presenting on consultation and how to get a patient aware of what's going on in their mouth.
That. We're going to be there.
Yeah.
My team.
Yeah, I'm going to be there too. And then we have a cranio. We have
Simkovich. I saw that too.
That we did a podcast with him, so he's speaking. Then we have other things on diagnoses.
Yeah, and then Pam doing her intro.
Right, and we have airway stuff. I mean, it's just a lot, and I think it's a great way for people to try to get involved with what's really going on with the joint, with the body, other symptoms. People don't put them together, and that's what we're here to do, try to put them together.
I know. I love this conference. It's my favorite one every year.
Yeah.
It's so fun, and it's such a great group of dentists that genuinely care about their patients, right?
Right.
So it's just so nice to get together with these people. I've been excited for this for a while.
Right. And you know how it is when you find somebody that's like-minded.
Yeah.
It's like you kind of suck them in, and you're like, okay, what do you do for this? Or if you have problems or some things that we can't get to the bottom of maybe so quickly or easily, there's always someone within ICCMO that you can put a question on the forum or call someone up that you met at the conference, and they're just so willing to help and just so truly, I think, invested in getting their patients healthy.
Yeah. It's really, I can't stress enough. It's a great group of people, and I'm hoping that more dentists will find out about ICCMO and start to join it. Yeah. So I'm trying to spread the word too. So that's always good.
Yeah.
Well,
do you remember the first time that we met at ICCMO?
Yeah, I met your team.
Right.
I didn't know people were bringing their team, so I came alone,
But that's okay. And then, do you remember, though, what we watched on TV?
Oh, my gosh. We watched The Golden Bachelor, didn't we? Yes. We stayed up late and we watched The Golden Bachelor. I hadn't seen any of it yet. So it was really fun. Yeah, but you guys were so warm and welcoming to me. And you were like, come to our room. We're drinking wine. We're watching The Golden Bachelor. It was so fun. Yeah. We stayed up late. It was really good.
Yeah.
It was fun. And then we had the idea of the podcast. I actually think your team had that idea. And even the name of it. So here we are.
I know.
Years later.
It happened like boom, boom.
Yeah.
We're like, okay. Yeah. We're going to do this.
Well, we just hit it off so well.
Yeah,
so
we did.
It was so easy. It was just seamless.
Right.
And then today's episode is all about answering your guys' questions. So should I start with the first question?
Take it away.
So I looked at the questions beforehand. I cheated a little. And I wanted to get Dr. Alex's take on this. Can TMJ cause Bell's palsy?
Yes. I don't know if it's TMJ caused Bell's palsy or what actually has caused the Bell's palsy, but seeing a neuromuscular dentist can help take the Bell's palsy away. So a patient that I remember from way back, her name was Lisa, and she came in and she was so droopy from the Bell's palsy. And I'm like, okay, what are we going to do?
How long had she had it? Do you recall?
She had it not too long. She probably had it a couple months maybe. And when she came in, though, it was very evident. And she's like, what kind? And she's like kind of talking out of the side of her mouth. I said, you know what? We'll take care of you. I'm not 100% sure what I'm going to do, but I'm going to do something. So we tensed her, which the TENS is an ultra low frequency TENS unit. So it's not like a TENS for pain. Like we said before, you can't like take something from your knee or for your back and put it on your face.
Right.
Don't do that.
It's a very special TENS unit.
Right.
So if you have a commercial one at home, do not put it on your face.
Right,
Yes.
right. So we TENSed her. I took a bite with my K7 to find, we took x-rays too, looked at the joint, and she had other signs of TMJ with what's going on in her mouth, with like the recession and things like that. And we TENSed her, we took a bite, and boom, her Bell's palsy went away. And it didn't take too long on her at all.
So you took a bite, you made an orthotic?
Yes.
And fixed or removable, do you recall?
At that time, I think it was removable.
Removable. So she took that in and out, and then...
But she wore it 24/7, other than took it out to clean it.
Clean her. Okay.
But she'd eat with it.
She'd eat with it. So her Bell's palsy completely went away.
Yeah.
And so have you treated multiple patients with Bell's palsy? Or because it's
I don't want to say I've treated a ton, couple.
A couple. Okay.
Yeah, because a lot of people don't even seek me out for
I know.
Bell's palsy.
That's why I was wondering. Yeah, okay.
Yeah.
And have you used the MLS laser on those patients or no?
At that point in time, I used, I think, just the warm diode.
Yeah.
Just, hovering above the tissue.
Yeah.
I didn't have my MLS laser at that time.
Sure.
Yeah.
Okay. Well,
but it worked.
It worked.
It worked, and
amazing.
She was happy.
She was probably thrilled.
Right. And then she went through orthodontics. We moved her teeth to that position. And I just saw her a couple weeks ago in the office, and she's still doing great. Yeah.
So we have a family friend that's had Bell's palsy since January of this year. And he just is so overloaded with so many doctor's appointments, because I said I would treat him and I'd try, you know. But he hasn't been able to make it in. So I'm just like waiting.
Well, does he live by you though? Is he?
He does. Because
I know
but he's
you have family
very embarrassed to leave his house because of the Bell's palsy. And then he has to leave already for so many other doctor's appointments. So it's like, it's a matter of like kind of talking him into it. So we'll get there.
Right.
Slow and steady. Yeah, we'll get there. I would love to have him come in. Just see what we could do for him. Or maybe I could just get a TENS unit to him.
Right.
Something. It's better than nothing.
Start to TENS, yeah.
Yeah. Okay, well, let's move on to the next question. Let's see. I'm experiencing headaches. What could be the root cause?
Well, remember we had your sister on too, and we talked about hormonal.
Sure.
Sometimes it can be hormonal. You've got to make sure too, I think, you've got to make sure that there aren't any kind of tumors or cysts or anything like that if it's something that's been a long time. But typically, I don't know about you, but typically when people come to you, aren't you like their fifth person they've been to? Said they've ruled out mostly everything medical.
They've had MRIs. They've been to the neurologist. They've gone everywhere to see what else could be going on, and there's no clear answer to their headaches. And then we do the whole exam, and their muscles are just hot, hot, hot. They're on fire. Right. So typically, it's referred pain from the muscles.
Exactly.
That's causing the headaches for our patients, right?
Exactly. Or the bite. So when you see a class 2 patient, when you have the upper teeth and the lower teeth, and the upper teeth really come over those lower teeth, and that lower mandible can't move, it's trapped, you've got to free up that bite, which then the bite is then tightening the muscles. So it's kind of like everything circles around.
Bite, muscles, nerves. Right. Yeah, it's all connected.
And the way the neurotransmitters in the brain and everything firing. Yeah. You got to get it under control. And
Yeah, headaches can have a few different root causes, but TMD can be one of them. Right. I guess that's the answer, right?
Right. And it's hard because every time you look about things and talk about things, you're like, yeah, it can be TMD. Yeah, it can be TMD. And I know Ashley's husband used to make fun of, it's TMD. And then guess who was treated in my office? Ashley works for me. Yeah. Her husband was treated. But you don't want to tunnel everything to TMD. But yeah, it can be related.
Sure.
And it can be related to other things too.
Sure, totally. If my jaw is clicking, but no other symptoms or pain, do I have TMJ? And what should I do to prevent the symptoms from developing further and getting worse? This is a good one. So with clicking, it's common to have clicking or popping, but that doesn't mean it's normal or okay. The clicking and popping noise tells us that the little disc of cartilage inside the jaw joint is coming in and out of alignment, right? And it can stay that way for many, many years, or it can progress to coming completely out of alignment where the jaw locks closed. So you never know if or when that's going to happen, and for who and why and how and when and where and what and why, all of those things, right? So I think it's better to get it checked out and treated in a preventative way to keep it from locking, and then to potentially even make the clicking and popping go away. A single click or pop is like the hardest thing to make go away completely, but you can prevent it from progressing. So I do think it's worth checking out. I recently had a conversation with a patient, a little girl. Her father contacted me, and he just said, she has clicking and popping. She's 11. And he said, but I've had it for years, and I'm fine. So like, does she really even need treatment? And he was asking for like peer-reviewed studies on exactly how to treat clicking and popping, and there's just not a ton of research for TMJ. And he's an MD.
Oh,
I know. I know. So I love my MDs, but they're, it's just, there's not a lot of research on TMD. So I feel like it's good to go to someone with a high success rate and kind of throw the peer-reviewed studies out the window for this type of treatment. They're just not there.
And then the people that are practicing like us, we don't have time to sit and write articles and
I don't have
collect data and do all that kind of stuff. We're too busy treating patients.
We're just or just with life. Like today I got up at 3:45. My flight was at 7. I landed at 10. I went straight to my mom's. We went to the bank. We went to lunch. From lunch we came straight here. And then we have a photo shoot, and then we have a board meeting, and then I'm going to crash. But that's my every day of my whole life, whether it's kids' activities or I can't do research on top of all of it, Yeah, I can't even fathom how to do that. So I was, it's hard because I do think MDs are a tough crowd. Every single MD I've encountered has those same questions, and then they don't end up taking treatment, and a good majority of them end up regretting it later. And it's just, they don't get the answers they want, but that doesn't mean we can't help them. And it's hard.
It is hard, but we're not for everybody.
Yeah.
And if MDs are so in the medication mode and they want to prescribe a med, and because there's some study behind it, but then you're not saying what all the other signs or symptoms that can happen because of the medication. And I'm not against medication, but I just want people to be aware of what they're taking and what it can cause.
Yeah, what it can cause. And then also, what is the root cause of the problem in the first place?
Right.
And
Why
is the
are we
medication
covering
just
it?
masking it, right?
Right.
I did have a patient come to me, and she said, well, I can either take a pill that makes my headache go away, or I can get an orthotic. And she was like, I don't know what to do. And I said, it's really up to you.
Right.
I'm here with one option.
Right.
And it's totally up to you. And she chose the pill. And I said, that's fine. I'm not here to push anything on anyone. But yeah, there's definitely options.
But back to the click.
Yeah.
So sometimes too, if you keep that disc is on top of the bone or the condyle and it keeps slipping and popping, the click can go away, but it could go away because scar tissue formed. So is that good?
Yeah, that's not great either.
Right.
Yeah.
So, I think a click and pop, in my opinion, should be looked at. Like, for instance, the other day I had a woman come in from Michigan, and she's like, oh, I feel better, this and that, but I have this click. I'm like, well, that's not, and we did T-scan on her. So I knew that she was hitting somewhere, sliding, and making the disc come off and click. And then by the end of the appointment, the click was very much reduced,
Isn't that
almost
crazy?
gone
Yeah.
in, 30 minutes. So the click you can get rid of, other than those, in my hands, other than the very extreme open, like a wide yawn. Yeah. That I can't always recapture.
Those are hard.
But any of those other little clicks in between, 9 times out of 10 we can. And it's usually an adjustment on the orthotic, the natural teeth, the porcelain, whatever.
Yeah. It's really neat to see the click and pop decrease drastically or just go away. People love it. People get so excited.
Right.
Let's see. Can TMJ cause tongue pain? Let me take that one.
Tongue pain.
I know. Interesting, huh?
It can, because you can think a lot of people brace their tongue in between their teeth in order to balance out their jaw.
Yeah. You looking at someone?
I'm looking at Ashley.
In our
burning tongue.
Oh.
Yeah. So I don't know. Tongue pain, though, some people will complain of tongue pain, but that is by like just their tongue kind of bracing between their teeth.
Using it as a...
So, and if you look at the tongue and you see those ridges, burning mouth, like Ashley so interjected, because Ashley's back there going, and I'm like, what is that?
Oh, I wouldn't have gotten that.
Yeah, I don't play charades that well, but people do say their tongue is burning. Yeah. Right, and that right. So yeah, it can happen.
Sure.
And yeah, when you think of everything that's going on, for sure.
And how everything's interconnected. Sure. Can dental work or braces cause TMJ? Yes. Dental work and braces can cause TMJ. And so when you're changing the bite, which dental work can do, even minor fillings, crowns, really any dental work,
right,
or braces, when you're changing the bite, moving the teeth around, if you change the bite in such a way that the muscles cannot handle it, it can excite the nervous system in not a good way, and the pain can start in. So yeah, definitely dental work or braces can cause TMJ. But
no, you got that.
Yeah, definitely. I see it all the time.
And a lot of times, I know when the girls are doing the consult, and when I come in at the end, they'll be like, their pain started around blah, blah, January, and they got a new crown maybe in November or something like that. And then I'm like, oh, okay.
Yeah.
Like when you kind of look at the timeline of when symptoms started, a lot of time it is when the braces came off, the Invisalign went in, a new crown or crowns went in, or a filling.
We had a patient that had an onlay, so that's kind of like in between a filling and a crown. It's a big restoration on a tooth, on tooth number 3, her upper molar on the right side. And immediately after getting the onlay, like when the anesthetic wore off, she started just having constant pain. She had never had pain before in her life. Constant right-sided pain, temple, face, top of the head, just constant 6 out of 10. And when she ate, it went up. When she ate food, it went up to an 8 out of 10. So she was just at her wit's end by the time she came to see us, because she's like, I don't know what's going on, but I can't live like this. She's like, I'm leaving town. I'm leaving the country to go work somewhere else.
Oh, geez.
And so she said, I need this fixed. And I had just gotten DTR certified. So she was one of the rare few that was one and done. You know, DTR usually takes a few treatments.
Sure.
She was one of the rare ones that was one and done, and she's doing great. Yeah. So it was that onlay. It just threw things off enough that everything fired up for her.
Wow. Did you replace the onlay or just adjust it?
No, I didn't even have to. I just adjusted and lowered her disclusion times, balanced her bite, and I told her, I said, if the onlay gets too thin or if something happens, we might have to replace it.
Right.
But yeah, it turned out really well.
Nice. I love that.
I love that too. I love that. How is TMJ linked to breathing issues?
That's a good question.
Yeah. Do you want to take it or you want me?
Yeah, well, either.
Well, if you're struggling for oxygen at night, like sleep apnea or its little sister, upper airway resistance syndrome, what happens is the body goes into like fight or flight mode. And we're not meant to like be in that mode for long periods of time or daily or nightly. And when we're in fight or flight mode, what happens is we tend to clench and grind our teeth with more force and more frequency, because it's a very stressful mode to be in. And grinding the jaw forward opens the airway. So it's our body's way of knowing, hey, this is how I can get a better oxygen saturation. But all that clenching and grinding night after night wreaks havoc on the joints and the muscles, and that causes TMJ problems. So breathing issues and TMD can very much be linked. They often come hand in hand, not always, but often. Did you?
Yeah, so one of the things too, like you were talking about at night, we always go through, the girls laugh at me because I'm like, did you go over the sleep recipe? You know, and you know, the tongue positioning, getting it out of the mouth. You got to make sure that, getting it out of the back of the throat. You got to just make sure that airway is open, and there's a lot more to that. But Yeah, with the clenching and grinding and the muscles overactive and hyperactive and constantly not resting. And a lot of times when you take on the K7 and you take a scan 9, and you look at when the teeth are just at rest and those muscles are firing, they're never resting.
Yeah.
And so we've got ways to look at the muscles to see exactly what's going on. And then when they lightly touch, they really start to spark up, and we're like, wow. And if you're grinding all night long, that's crazy.
Yeah, definitely. Let's see. What happens if you don't treat TMJ symptoms?
You'll be miserable. That's just the way it's going to go.
Yeah.
Right?
It's a chronic progressive disease, right? So it typically doesn't get better on its own. The few cases I've seen that get better on their own are like someone bit into an almond just the wrong way and they sprained or like strained a ligament.
Yeah.
And then I say, okay, well, if you've never had any history of TMD before,
right,
and you're having some pain right now, let's wait like 6 weeks and see how it goes. Right. So there's a few people that are like, I'm actually fine now. And there's a few people where that was the straw that broke the camel's back and they need to start treatment. But for the most part, it doesn't just go away.
It doesn't get better. And then what happens too, your teeth wear down, your joints and your bones and the way everything comes together in the joint, you're going to start to get some bony changes. And a lot of people say, I look like I've had a stroke, or my one side is so much more fuller than the other, and it's not going to get better.
No.
You might be able to tolerate it because you'll be able to, take meds or warm compresses or things like that, but it's not going to get better.
Yeah.
Not going to get better.
No, yeah. Totally agree. This is our favorite one. Is Botox an effective TMJ treatment? Botox.
The good old Botox. I think if you're in a very excited state and very need something now, but sometimes Botox doesn't work after the first time you get it. You got to wait another 3 months. But I don't mind it for that. But long term, I don't like it.
Yeah.
But, to each his own. But that's my opinion.
Yeah.
I'm not a Botox proponent. We've talked many times about Botox and what can possibly happen to the bone. And you're putting something, like you said earlier, you're like, we want to get to the problem. You don't want to get to the problem and you want to use Botox. Okay.
Yeah.
That's your choice.
Yeah.
But that's not where we come in.
Right. And, it's also a neurotoxin. They call it a neuromodulator to make it sound pretty.
Right.
And it also, if it's injected into the masseter, it'll atrophy that muscle so much that if you already have sleep apnea, it can exacerbate that because when you sleep, the jaw just drops further back into the airway because the masseter is so weak. So I feel
the main lifters and positioners of the jaw are the masseter and the temporalis muscle.
And that's where they're injecting all the time. So, and then oftentimes the pain is coming from deeper muscles, the medial pterygoid, the lateral pterygoid, which are not injected with Botox. So you're not even getting
SCMs.
to even the SCMs. Yeah. And so I think we're very much on the same page with Botox. I think I have it in my office for a hygienist that comes in and gets it for cosmetic reasons. So it's not even for TMJ, right? So is physical therapy an effective TMJ treatment?
I love physical therapy in adjunct with my treatment.
Right.
Physical therapy, I think people get relief from it. I think that the jaw, like the playing field has to be balanced first. Then we got to get the muscles to hold everything in that position. And some people are so wound up that they need a lot of physical therapy to help unwind, like Zane. I see Zane over there. Her hips, her pelvis, like so many things are just so tight on her that we need to not just look at the jaw, but I've got to look at the rest of her body. And we had Josh on before. He's my physical therapist that I use for my patients, and I love him. I mean, it'll help. It's kind of like if you don't get TMJ treatment, like if you can't get to a a neuromuscular doctor or an ICCMO doctor or something like that treats a lot of TMJ, it's you just have to do something.
Yeah.
So yeah, PT will help you through things, but it's not gonna, in my eyes, cure it.
Right. Okay. And with the PT, your physical therapist, I know we talked about this in the other podcast that he was actually on, but I'm just going to ask again. Does he work with the patient on a lot of exercises, or is it more stretching and posture?
A lot of it, I think, is more stretching, posture. He does do some exercises, but I have him go very slow on the exercises of the mouth because that's very, very tricky. Like
it can be triggering to the pain. Yeah.
Yep. So I want to get things. I don't mind if he goes in there and releases the muscles inside the mouth, but I don't want him giving them chin tucks and things like that. I'm like, no. So
some of the exercises can be a little bit too much. And I think when people hear physical therapy for TMJ, they immediately think exercises, because a lot of physical therapy in general is exercises. Right. And so I think people think, well, if I strengthen the jaw muscles, then everything's going to get better. And that's not always
right. Yeah. You don't know what muscles you need to strengthen.
Yeah.
Like, let's
or which
look
ones
at
are
your
overworked.
Muscles. Right.
Why would you want to strengthen an overworked muscle?
Right. You got to get it relaxed first before you can bring it. I agree 100%.
Yeah. So it's like finding the physical therapist that understands like how we treat TMD and working well together with that person, which I have only found one in my area.
Yeah, it's hard
tough
to come by.
It's really tough to come by.
But you just don't want them just to look here, because this is connected to, guess what, the rest of the body. So we've got to look at that too.
Yeah.
You know, and the neck is so important too.
Yeah. Yes. When should someone consider surgery, and what kinds of surgical options are out there? What are the risks versus benefits? That is a big question.
Yeah, so when it comes to what surgical options are out there, I don't really ever want to do surgery. In all of my practicing years, I've sent one patient to get surgery, but it's because her coronoid process, not the condyle, but the coronoid process was overgrown. But yeah. She was a headache patient, and then her jaw didn't move right, so we had to get that shaved down. But I made her go to Detroit to an oral surgeon that is neuromuscularly trained.
Good.
And I didn't know there were any. He's the only one in the country.
Yeah.
And he's probably Gary Wilfred, Dr. Wilfred. He's awesome.
I know him. Okay.
He's awesome. So I went up with her to Detroit.
You went with her? That's so nice of you.
Yeah, because I'm like, this is the only person I would want to touch you.
Yeah.
So, and we had her in an orthotic.
Yeah.
And then he did surgery, moved her into the position, and she's been great.
Oh,
She'll
good.
text me, probably once a year around the holidays. Hey, I'm still good.
She's still good.
Probably about 10 years out.
That's lovely.
But surgeons know about surgery.
Sure.
And I can't really talk on that. I mean, I know there's a Lefort 1, Lefort 2. I know, what they'll try to do. But in my eyes, and this is just my opinion, but in my eyes, I think when people line the jaw up for surgery, they're just eyeballing it. Well, and in the mouth, you're a 0.5 millimeter off. That can send you into disarray. But the other thing, too, with surgery is a lot of times they're just looking at the bone.
Mm-hmm.
They're not looking at the tongue. Mm-hmm. And then if that tongue is tied and they do a surgery, it's going to relapse because the tongue doesn't know where to go. Mm-hmm. Mm-hmm. So my daughter, who's a resident at Denver Health, she's a dental resident now.
Love that.
She just started in July.
Yeah.
Anyway, she was in a maxillofacial surgery. Yeah. And she called me after the surgery, and she's like, Mom, and the surgery was like 9 hours. And she says, this woman, her tongue kept getting in the way. Oof. They couldn't get everything together and blah, blah, blah. And I said, what did you do? Now, she's just a resident, so she was not doing the surgery. She was just observing. And she said, I asked the surgeon if he can lift the tongue up so she could see underneath it. And she says, Mom, she's tongue-tied. They're never going to get her down and closed. And then the surgeon looked at her, and she's like, I just wanted to see.
Yeah,
her little sweet self.
I just wanted to see. Yeah.
Yeah, and then they probably were like, oh, crap. That tongue is in the way, you know?
Yeah.
And,
well, yeah, totally. Well, I mean, I think there are some instances where surgery is appropriate. Like, for example, I saw a patient who came to see me, and she looked, and I'm not doing this to make fun of anyone, but this is literally how she looked. Mm-hmm. Her jaw was way off to one side, and she showed me pictures from like 5 years ago, and it wasn't like that. It was all lined up. And I thought, what the heck is going on? So we took a CBCT, and her condyle was growing, just growing and growing and growing.
So it was
and growing.
hyperplastic.
It was hyperplastic.
Yeah.
Yeah. And so it just kept growing. And so for that reason, she went to a surgeon. They did a bone scan to show that it was still actively growing.
Well, do they have to wait until it stops growing before they do the surgery?
He didn't. He just cut off the part that was growing, I think. She's doing great, though. Good. She emailed me, and she was so grateful to me. She was like, thank you for not just taking my money. Like,
that's like the hyperplastic coronoid process.
I locked.
But she was done growing. We had tests to make sure she was done growing before Gary did that.
This one was still growing, I think. And so I just left it in the surgeon's hands because there's nothing I can do if her bone is just growing and growing and growing.
Yeah.
But for most muscle and disc related issues, I don't think surgery is a good option.
No,
so,
I don't either.
Yeah.
But, you know, and I've found too in my area anyway, it seems like more and more oral surgeons are doing less and less surgery.
They are. There's one that met with me just in our area, and he was like, I don't even want to do any type of surgery on disc related issues unless they've seen you for like 6 to 8 months and tried something conservative. And even then, they don't really want to because they're just like, the success rate is so low.
Right.
You know?
Right.
So, and even, you know, patients that get kind of impatient when they're not unlocking as fast as they want to, they'll get the, what's it called? Arthrocentesis. I'm like, why am I forgetting? Yeah. Arthrocentesis, and they unlock for 3 days. And then it locks right back up.
Yeah.
It does not stay unlocked with arthrocentesis. Yeah. And so surgeons know that too.
Right.
You know,
and it really comes down to the muscles and the way you're functioning, your chew cycle.
Your bite.
How you're chewing.
Yeah, how you're chewing. It comes down to so many things. And so just, you know, flushing the joint out and putting everything in alignment for a little bit, as soon as that fluid dissipates and you go back into function with chewing, boom, that disc is out again. So, surgery for muscle and disc related issues, I don't recommend, but for like areas where the bone is like growing. Right. Yeah, of course. Of course, sometimes it's appropriate. Let's see. Should we do like 2 more?
Sure.
Okay. Oh, this is a good one. How long does it take to feel relief while undergoing TMJ treatment?
Okay. That is a good one. And it varies, obviously, for everybody and what your symptoms were. Like, I go over all the signs and symptoms and, you know, it varies. But typically, we tell our patients maybe 60 to 90 days. You know, some patients could be longer. Some are a lot shorter. And we're like, wow, we nailed that pretty quick.
I know.
But
you never know who's who or
you
why.
Don't. You don't. So it depends. Everybody's so different. It's like saying, how am I going to heal after surgery? Well, if you're a diabetic or a smoker, it's going to be a lot different. So, you know, everybody's different.
We usually tell our patients, like, within 2 months, you should feel some relief in some symptom, like in something, right? I'd be surprised if you didn't. Right. But I've had patients with DTR and with orthotic treatment where they're feeling really good and then they have a regression.
Oh, sure.
So TMD is like 2 steps forward, 1 step back, 3 steps forward, 1 step back, 2 steps.
It's a roller coaster.
It is. It's a total roller coaster.
Really
it's never linear. It's almost never linear. For some people it is, and they're the lucky few. But for most people, there's some point in treatment where there's a regression, and it usually coincides with a stressful time in their lives. They're moving,
and
they lost
the
their
body
job.
just doesn't sit still, and then the muscles have memory and want to go back to how they were. So you can sleep funny on a plane, and then some things happened because now the neck muscles are pulling funny. That's pulling the jaw. So, everybody in our bodies are just always on go.
Yes.
So things are always changing and moving.
Yes.
But the good thing is that when the treatment's completed, it holds because the body, it's like, I always tell my patients, don't worry, I'm going to win.
Yeah. Oh, don't worry. I like that. I'm going to use that.
Your body.
Yeah.
They haven't met me. I'll figure it out.
I'm going to win. I like it. I'm so going to use that. Okay. Last question. How do experts evaluate and correct a bad bite without causing more harm?
I think that's a good question, but I know the way that we do it is using the T-scan a lot, looking at CBCT scans, looking at the position of the joint, looking at the activity of the muscles. And then there are people that don't have that kind of equipment, and I don't know how they do it, but they're trained. They're trained somehow. But I think the way we are, we're really looking at the body and we're looking at how everything fits together in harmony that makes the muscles happy.
Yeah.
And that's what you've got to do.
I like that we're looking at like how the muscles are firing.
Yeah.
And using the T-scan and doing DTR therapy is really good data that we're looking at with a high level of precision and accuracy, right? And so I was teaching a course recently, and there was a dentist that kept asking what the difference between occlusal equilibration and DTR therapy was. And I explained it like before he asked the question, after he asked the question, and then again he asked the same question. And I was like, I am stumped on how I can be more clear because I very much explained like the difference in the sensor and how accurate it is versus how we were taught in dental school. Like the size of the mark does not correlate with the force.
Correct.
Right. And so I explained that as best as I could, and it just wasn't sinking in.
Well,
so I'm going to let you try.
The whole thing is, too, when you're talking about DTR and you're looking at these marks, a lot of time where the problem lies, and I think this is probably a little bit with Zane, too, where the problem lies is like that initial hit.
Yeah.
Like if you look right at the A1 and whatever that first tooth is, because I'm like, you're 50-50 when you clench. But that initial hit kind of throws the jaw or makes it slide. And that can be at like 0.01 of a second.
Right.
How do you find that with just equilibration?
You can't.
You can't.
Yeah. It doesn't show it. You don't have.
So you're looking at stuff more precisely that you can really tune in. But when you're just using paper and you're equilibrating with paper, you don't know what's first, what's last, where
you don't know
you're
the timing
sliding.
of it.
You don't know any
or
timing.
the force.
Right.
Yeah, either. You don't know timing or force. I was pretty tired that day, so maybe I didn't do a good job explaining it, but that was perfect.
Oh, thank you.
Yeah.
Thank you.
Well, thanks guys for joining us for this session of Unclenched, and we hope to see you all at the next one too.
Thank you. And also look up ICCMO if you are a dentist and try to get a little bit more training because you can help your patients just like Priya and I.
Yes. All right. So be sure to follow us on social media. You can look up the Unclenched podcast on anywhere you like to watch podcasts. And then I, of course, have my own Instagram and TikTok and all the things. So just look me up at the TMJ Doc with underscores between the words.
And you can find me with Pittsburgh Dentist on Instagram and TikTok. And we also have YouTube, and that's Pittsburgh Dentist.